Good afternoon. I'm Dan O'Hare, Dean of the College of Communications and Information Studies at the University of Kentucky. Our college is known as a world-class research program that focuses on health communication and risk communication. Our research scientists have established that developing effective messages is one of the most important strategies for improving the health of our citizens. Without effective communication, advances in medical science have much less potential to make a difference in people's lives. We can improve health communication by improving health literacy. Health literacy refers to the ability of individuals to obtain, process, understand, and communicate about health information and to make informed health decisions. Some individuals are bewildered by the complexity of the healthcare system. Others cannot understand what is printed on their prescription drug labels. Still others do not ask their doctors questions for fear of appearing dumb. Most of us have trouble understanding what our health insurance covers. Health literacy is a growing need in Kentucky and in this country. Our college is excited about this opportunity to partner with other organizations to promote and improve health literacy. That's the purpose of this series. In 6 public forums, we will investigate what health literacy is and how we can improve it. We will talk with experts from a wide range of areas. In these frank and open discussions, we want to identify people, issues, assets, and opportunities that will lead to programs to improve health literacy. The forums will be recorded and placed on our website. Please take the time to comment on the issues we raise and make your own contribution to improving Kentucky's health literacy. In this first colloquium, we want to explore and emphasize the need for health literacy, especially here in the Commonwealth of Kentucky. Our guest panelists are Dr. Lee Todd, President of the University of Kentucky and an ardent advocate for health literacy and health promotion. President Todd is a native of Kentucky and a champion for improved health in Kentucky. Mike Childress, former director of the Long-Term Policy Research Center and now a policy research analyst for our college, the Gatton College of Business and Economics, and the Martin School for Public Policy. Deb Miller, a health analyst from the Council of State Governments. And Dr. Pamela Stein, a research scientist from the University of Kentucky College of Dentistry. Moderating the discussion today is Al Cross, an award-winning journalist and a faculty member in the College of Communications and Information Studies.
Thank you, Dean O'Hare. I'm the director of the Institute for Rural Journalism and Community Issues in the School of Journalism and Telecommunications in the college. So I have an abiding interest in health and health literacy. And we have some folks at the table today who also have that interest and are going to begin what we hope is a series of very productive discussions about the topic. Our first guest is Dr. Lee Todd, President of the University of Kentucky. Dr. Todd, you, the university, and Humana Incorporated co-sponsored a health literacy summit in February 2010, and you actually attended it personally and gave a kickoff address. Why are you so interested in health literacy?
Well, Al, I think it starts with the fact Patsy and I are both native Kentuckians, and we get tired of hearing about the problems of Kentucky and how we rank so poorly in areas where we don't want to be leaders. There are areas we want to be leaders, but when I first got this job, it hit me when I went to Hazard at the Rural Health Center, and I got out on the elevator on the 2nd floor, and here were all these statistics about the health conditions of that area. And I made a comment to the person with me. I said, boy, this is just ugly. And I changed my speech that afternoon, and I came up with this Kentucky Uglies term, which my PR people didn't initially like, but it seems to have stuck.
Hard facts deserve hard talk.
You got to face the problems. If you don't talk about them and face them, then you're not going to solve them. And I love getting data and information, and they had it. And the question is, how do you solve it? But one thing that I also feel very pleased with is I realized about that time that I was now had a job in Kentucky where we had assets that we could use to attack that. And we looked at the extension agents. We put in a program called HEAL, Health Education Through Extension Leaderships, because we're in every county and they could carry out health care information. We started a program called Commonwealth Collaboratives, where we asked the faculty to find problems in Kentucky where people were locally working on those problems, but they didn't have the research skills that we had. and for our professors to merge their research capabilities with the local communities. Find something you can measure. I'm a big one on measuring whether you're making progress or not. We've really had a major impact on smoking cessation with one of the collaborators at Ellen Hahn in nursing has championed. Dentistry has done a wonderful job in Hopkins County looking at low birth rate babies or preterm babies and low birth rate situations. And so we have the ability as a flagship university to call people together like the Health Literacy Summit you mentioned. The real key though is a lot of universities do that. But we want to take action, and if we don't solve the problems, if we're not a part of the solution, and we shouldn't be bragging about being a top university. And what I really appreciate is that Dean O'Hare comes in, puts this colloquium together where we can put speakers together who can have a conversation about these issues. And then we can take those and hand them out to different parts of our university to attack those problems and make some headway. The final thing I'd say that makes me interested is I've watched our budget be diminished ever since I've been here. It's clear, and it's a national problem, that prisons and the healthcare are eating the education budgets. I told a group the other day, you know, it's one thing to be, we don't want to be soft on crime, but as a result of being as hard on crime as we are in Kentucky, we're being soft on education. If we can reduce Medicaid expenses, if we can improve the health care, we can improve the prison budget, we'll have money for health care. And that's one of my other strong interests, and I'm really eager to be a part of this colloquium today.
Well, it's been said that a lot of health illiteracy is just plain old illiteracy, and that's where education comes in, right?
Absolutely. The things that we could, if we can talk our people into avoiding certain habits, and I know I'm not the best in the world at it, but I wish we could get the passion of Kentuckians for athletics, where we want to be number one or in the Final Four, to direct it towards some of these other measures. All right, let's pick one and let's knock it down. Spina bifida, if you just take the vitamins, that goes away. Why is that so hard? And I think literacy is really the fundamental piece. But then you got to have people close to those in public health or in the field with our extension agents to keep reminding them. But I'd like to see some local goals set in communities where they take their passions and say, let's whip this thing, let's straighten it out for the next generation.
Well, I'm an extension professor, so I really appreciate the role of the extension agents and the HEAL program. And you know, they have this fine program called Second Sunday, where people get out and it becomes a community event, and health becomes kind of a community cause. What's the role of a land grant institution in those kinds of measures?
Well, I think that you know, land grant, I think originally with the Morrill Act was targeted more toward agriculture because we were an agrarian nation at that time. My feeling when I came in was that, and I've given some national talks to extension agents around the country, that if you continue just to focus on ag, you're going to have a problem because your budgets may get cut. You need to reach out and contact other issues. We have you in journalism as an extension agent. We have 3 fine arts agents in Pikeville, Muhlenberg County, and Greenup County. We're the only ones in the nation to have that. And the HEAL program has just been something that was started as, this is probably in its 6th or 7th year. And I think our role is to, people will listen to universities speaking out. We need to have articles in rural papers that will tell them the things we know. And then again, we have these people in the field. And so those are assets that we can use to change people's actions.
And not all land-grant universities have a medical center like we do.
Absolutely.
And a dental school and a college of pharmacy.
We're one of only 8 universities in the country where we have everything on one campus. But what's beautiful about the medical center, and we're building that brand new hospital, is that they are doing their best to keep patients in their beds in their rural communities, as long as the rural medical facilities can take care of them. But then when they have severe problems, come to us. And so we're not just trying to rob them and make money. And the other thing with our dental program, the amount of work that our College of Dentistry has done in care throughout rural Kentucky is not yet appreciated. And I think that, but that is a unique piece of our land grant mission, is that we have health care throughout the state as well. And it's something we've really got to use to help solve these problems.
And we'll be talking with Dr. Stein from the College of Dentistry about that later in the program. But Michael Childress, the purpose of health literacy really is to improve health,
right,
and help people make better health care decisions. Just how healthy or unhealthy is Kentucky compared to other states?
Well, unfortunately, we're very unhealthy compared to other states. There was a national organization that does they do a ranking of all the states every year. And I think in the most recent version of that ranking, and they use a number of indicators of health outcomes, we were ranked 41st. And I think that that's indicative of the fact that with respect to the percentage of our adults who smoke, we're number one. With respect to the percentage of our adult population who are obese, I think we're number 3. We have, with respect to our children who are either obese or overweight, we're in the top 5. With respect to oral health, the percentage of our population 65 or older, we're in the top 10. I think we were 7th in 2008 in the CDC's behavioral risk factor surveillance system data. So all of these indicators, and they've been that way for a long time, and unfortunately, they're not necessarily moving in the right direction.
Yeah, what do the future projections show?
Well, we actually did an analysis of some of the behavioral risk factor surveillance system, both oral health data and some of the smoking and obesity projections. But the thing that is particularly bad about our high smoking and obesity percentages is that those two indicators are huge causes of chronic disease and disability. So they're very costly, okay? It cost our state, Dr. Todd talked about the Medicaid budget. To a large extent, the reason that it has been increasing the way that it has is because of the choices that a lot of our citizens make, that a lot of us make, in not pursuing healthy lifestyles. And so when you project out where a lot of the states, you've seen a downward trend in the percent of the adult population in smoking. We projected out to 2020 using a statistical model that factored in changes in education and age profiles.
Birth rates.
A lot of different fundamental socioeconomic factors. Obesity was, I believe, declining slightly, but smoking was remaining stable, whereas with a lot of states, smoking has been declining. Now, part of that has to do with the fact that and this changed a few years when the Kentucky General Assembly and the governor decided to increase the state excise tax on a package of cigarettes. And we know that if you increase the price, you reduce the demand, particularly among young people, which is especially important, keeping them from ever getting that habit. But we still have a relatively low tax rate with respect to cigarettes. And look, I mean, it's the political reality that we face. We are a tobacco state, and so it is what it is. I think that.
But we're much less of a tobacco state than we used to be in terms of the number of people who raise it. I mean, we used to have upwards of 50,000 tobacco farmers, and now we have much closer to 5,000, which removes the political punch. Doesn't it? Yeah,
I think that the political punch has been softened. I can remember when I first came here as the director of the Kentucky Long-Term Policy Research Center in 1993. The very first study that we did was on the future of burley tobacco. And I was warned that that could be the first and maybe the last study of the Kentucky Long-Term Policy Research Center.
But you grew up in tobacco country. You're from Edmonson County. You know about that.
I grew up standing on tier poles, hanging tobacco. And that was the only thing that kept them from blowing us up, I think, is because I had those kinds of credentials.
Is it easier now to make people more health literate about the consequences of smoking because tobacco has declined in importance and political punch?
Oh yeah, I think so. I mean, look, how long has it been? 5-6 years since we had the restaurant smoking ban here in Lexington, in Fayette County. And I remember telling people then that had that been attempted sort of 10 years earlier,
right,
it wouldn't have gotten any traction at all. Okay, and so times have changed, and it is easier, I think, to get people to embrace and absorb the importance of pursuing healthy lifestyles. But the trends are still not moving in the direction that I think we would like to see them moving in.
And how much impact do you think improved health literacy could really have on health status? Have there been studies that indicate that?
Yes, and it can have a huge impact, okay? In part, it has to do with just simply being literate, okay? Being able to read and process and understand and obtain the necessary information. And so there have been a lot of research studies that have touched on that directly or indirectly that, well, demonstrate the efficacy of menu labeling legislation, which was something that was proposed in the last session of the Kentucky General Assembly and didn't get out of committee. Okay, there have been studies that have shown that these having a menu posted in a fast food restaurant with the calories is effective in reducing the number of calories purchased and consumed on a per person basis. Okay, and there have been some very elaborate research studies on that. So we know that improved health literacy makes a difference. The other part of this, though, is that, look, we all know that smoking's bad for you. Okay, there are people with PhDs who smoke. Probably PhDs in health sciences who smoke. They know, yet they still do it. Okay, and look, I know that eating ice cream and birthday cake is bad for me, and I still do it. Right?
Not once a year.
Once a year. That's right. Fortunately, I have a lot of birthdays that I have to deal with. But
okay.
So I think the other part of this is to create, and this is where the policy aspect comes in, to create an incentive structure to encourage people to act on the information that they know.
Thanks, Mike. Deb Miller, you're a research analyst for the Council of State Governments, which many people don't know is actually based in Lexington. What kinds of research has been done at the state level, here or elsewhere, about the impact of health illiteracy and the possible impact of improved health literacy?
Well, there's no question, as Michael said, that illiteracy is directly related to health outcomes. And I think, as Dr. Todd pointed out, certainly education in general is a piece of that. I think another piece of the health literacy, and an example that we've just seen, is around the healthcare reform debate that this country was engaged in the last year and a half, and that takes it even out of some of the Kentucky ugly kinds of settings, but really begins to show how illiterate many of us are about health care and health insurance, and what's the difference between your deductible and your out-of-pocket maximum, and do you understand that pre-existing conditions exist? And the public clearly in this debate understood that health care in general was broken. I mean, I think all the polls would indicate the American public agrees with that.
They were unhappy with the status
They were
of the system.
unhappy. On the other hand, they're also unhappy with this bill that passed. And I would submit partly because, frankly, many of us don't understand it.
There was a poll came out just shortly before we taped this show, which shows that most Americans simply do not know what's in that bill, as the Associated Press put it. They sponsored the poll. What's the answer to that?
Well, I think some of it is exactly these literacy programs and education sessions. You know, I've sort of broken the bill down into 4 kind of things that, you know, you constantly hear. I think I heard on the radio this morning a politician one more time reminding me it was a 2,500-page bill and how could we possibly understand it. Well, there's sort of 4 things you need to understand about the bill, in my opinion. The first is that it's not a government takeover of health care. In fact, most all of us will continue to get our care from our employers, and it's a partnership of employers, government, individuals, and consumers. So
but it is more. It is a greater government regulation.
There
of
may
that
be
system.
more government regulation, but I would submit the regulation works. The second principle is that health insurance reforms will really help consumers. We're getting rid of today. If you've read the newspaper or seen the news or listened to the president yesterday, he reminded today is the 6-month anniversary of the day the bill passed, and certain things go into place today. Children can't be excluded for pre-existing conditions today. No lifetime limits on your insurance today. And a few other provisions as well. And then I think thirdly, which will begin to address maybe not the literacy piece, but some of the other uglies and the consequences, is coverage will increase. And while in one way it will exacerbate the Medicaid problem because it is through this state-federal partnership, but more Kentuckians, probably up of 200,000 Kentuckians in our state, will end up being covered under the Medicaid program. So I think there's some very important kinds of things for us to think about, and to think about the literacy and understanding the bill and understanding how to use our own insurance. I know that extension agents help with some of that.
I think many people who hear the term health literacy wouldn't think about including health insurance literacy or health care literacy as part of it, but it is certainly a big piece of the problem. There's been an estimate, a wide range of estimates actually, of the cost to the U.S. economy of low health literacy. It ranges from $106 billion to $238 billion a year. Can you narrow that figure down at all? That seems to be a fairly wide range. 17% of all healthcare expenses, potentially, at the high end.
Well, I think you've got a number of things. We've already talked about preventive things that were because we don't understand prevention and wellness activities, and we don't change our behavior. So some of those costs come through more obesity, more diabetes, more treatment. I think some of them come through with over-treatment. I would submit that some of the literacy debate also among people who have coverage is those of us who walk into physicians' offices and demand the newest and latest procedure or drug or pill to fix whatever it is we have. And we're spending some of that extra money on those kinds of things as well. It's sort of a twist of literacy that we don't always think about.
Thanks, Deb. Dr. Pamela Stein from the College of Dentistry, welcome.
Thank you.
You have a presentation for us, I believe, on this topic, and you may proceed.
Thank you. Thank you. Well, first of all, thank you so much for including me in this conversation on health literacy. I'd just like to speak a little bit about why oral health is important to the conversation. We have very poor oral health in Kentucky. I think most people realize that. We have very high rates of untreated decay among adults, some of the highest in the nation. We are in a race every year with West Virginia for the highest edentalism, which is loss of all teeth. And for our children, we are really no better, if not worse. Our children suffer from very high rates of untreated decay. 1 in every 8 children in Kentucky has had a toothache in the last 3 to 6 months. And we have something called early childhood caries in Kentucky, high rates of that. And that is dental decay that affects really young children, 2, 3, and 4 years old. And we have very high rates of that in Kentucky, maybe because of health literacy issues that can be caused by putting a baby to bed with a bottle, putting soda in a bottle. It's often called baby bottle caries. But it can also be caused by transmitting decay-causing bacteria from the caregiver to the baby, and I think a lot of people don't know that. So
they don't even realize bacteria can cause caries.
Exactly, right? Exactly. So we have a lot of adults in Kentucky that have untreated decay, and the bacteria in their mouth can be transmitted to their babies by kissing the baby on the mouth, by sharing utensils, any saliva sharing activities, and then the bacteria is in the mouth of the baby and off and running. And these early childhood caries are really a bad thing to happen to a child. That the teeth can decay off at the gum line, cause infection, and many times they have to be treated in hospital operating rooms under general anesthesia. You know, and I think these types of things cause a lot of pain for Kentuckians, disability, there are nutritional consequences, and it's easy to make the link to systemic problems if you think about the nutritional consequences. But I think there's a whole host of other linkages that we don't, that a lot of people don't know about. There have been literally hundreds of studies in the last 20 or 30 years that, that suggest poor oral health, specifically gum disease, is a potential risk factor for some pretty serious systemic diseases like stroke, pneumonia, diabetes.
We see those on the screen now.
Yes. Dementias, we're just really starting to look at that now. I have the mechanism for this, so if you think, well, why would it be that gum disease would increase someone's risk for something like stroke? The bacteria that causes gum disease is very pathogenic. These are very bad bugs. They get access to our bloodstream, travel around in our systemic circulation, and cause a whole host of problems like inflammation in the blood vessels, an increased propensity of the blood to clot. So these are some of the things behind that association. I think a lot of people are unaware of that, that there are so many oral systemic linkages linking poor oral health to some really bad systemic diseases. I've given an example of one study. I used diabetes because we have such a high rate of diabetes. I think we're about 4th in the nation for diabetes. And we've had some really good quality studies that suggest poor oral health, specifically gum disease, decreases the ability to maintain glycemic control and increases complications and even mortality in diabetic patients. So what are we doing as a College of Dentistry to address these issues? Well, we have recognized this as a problem that's so big we have to have help. And as Dr. Todd mentioned, we're trying to engage in partnerships throughout the state. We've been working on this for about a decade. We have developed something called the Kentucky Oral Health Network, and we have partnerships throughout Kentucky, partnerships with Kentucky schools, Head Starts, nursing homes, hospitals, public health departments, and through those associations, we've been able to really develop some great outreach programs. Our mobile dental programs, we have several mobile dental programs, and in addition to delivering care to vulnerable Kentuckians, we also provide education to Kentuckians. So we're trying to address literacy in that way. In fact, the first part of our goal statement is to improve oral health literacy. So we're keenly aware of the part that plays in solving the oral problems that we have in Kentucky. We've also participated, as Dr. Todd mentioned, in the Centering Pregnancy Program in Trover to try to improve birth outcomes. I've had a lot of success with that, educating the pregnant moms. We've developed
This is in Hopkins County.
That's
right?
in Hopkins County in Madisonville. We've developed a workplace wellness program where we're going into the workplace and educating adults as to the importance of oral health, doing some exams and getting them referred out. We're working with diabetes educators, physicians, nurses to make sure we're on the radar. They're currently developing a new state plan for diabetes, making sure that oral health is in their mind as they work with their patients to control outcomes. And so we're really doing a lot more than that. I know we don't have a lot of time to talk about. We're very involved in the coalition, the Health Literacy Coalition that was kicked off in February. We have several faculty members involved in that. So we're really, I think, engaged in outreach and appreciate the role that literacy plays.
Yes, the Health Literacy Summit had as one of its goals the creation of the Health Literacy Coalition. Its elements are supposed to be education, awareness, research, and then the healthcare system itself. I warned you I would ask you this question. Do you think that providers are really listening to the issue of health literacy and trying to address it with their patients?
I think that they are, because I think they're aware of the outcomes are dependent upon their patient being able to understand them. And I think, and we've talked about literacy being two different things really, being literate and able to read when I give you a consent form, you know what I mean before I take your tooth out, and being literate, understanding why oral health is so important. And I do think that providers understand the importance of both of those literacy issues. I think the problem is, well, what do we do about it? And we're so busy trying to treat our patients, and you know, we really didn't have education on health literacy issues when we were in dental school. We do now because I teach the class that teaches that class. So I'm making sure they're getting it now, what to do about patients that are reading at a first and second grade level and how to help educate the public. But I think providers are just really busy and they don't really have those tools in their toolbox to know what to do about it.
Well, Dr. Todd, it must do you good now in your last year as president of the university to see some progress on this issue, particularly in your native Hopkins County with the Centering Pregnancy program. Can you talk a little bit more about the details of that and how it all happened?
Well, I know the data for the first, I think 18 months or so of that effort, and they were able to get expectant mothers to come together. It had a dental exam component to it. It had kind of a social impact. One of the stories I heard is that some of these mothers probably, once they were convinced that their health condition was going to affect their child, then they got more serious about it. If it's just for them personally, they might not have come in and been a part of it. But so I think there is an aspect of how do you sell the fact that you got to have better health care, and through the children is one way to do it. When the president of Trover Clinic introduced me on their Founders Day, he had indicated that during the term of the research we were doing with their public health group as well, that they had reduced the number of preterm births by 37. And that really does change not only that child's care at the very beginning of their life, but also throughout their life. And that if you calculated the cost of Medicaid for taking care of 37 preterm births and their issues, it'd be $1.9 million. And so those are the kind of things I think this state can use that fact and that information, let's get out and do it. The hard part for universities is that we can do the front end studies and we can go in there with the power to get things shown on a pilot basis, but how do you make them sustainable? And that's where it really takes the state health department, the Department of Education and so forth to get out there and do that. What I'm really excited about is this colloquium and the idea that we have a dean who is really looking at health risk communications, because we know these things and we can tell each other these things, but how do you get a big population to appreciate it? If they just got their blood test and their A1C measured, they might not become diabetic. They may not have to have their leg amputated later in life. And one of the statistics I saw at Hazard was the number of people with diabetes in that area who were undiagnosed. They don't know it until they start having symptoms, and by then you're in trouble. And so, and with the new insurance plans, possibly the upside to that is it may cost us more on the front end as we have more people that have coverage, but it may solve a whole lot of later problems that are very, very expensive and life-changing. And so I'm very proud of what all is going on now, and I just want to start seeing some of these numbers go down. I know we stopped smoking on our campus in our medical center. We got very little pushback from that. We got a few emails, but we are reducing the amount of smoking in the restaurants around the state. Sooner or later that's going to have an impact. And the price increase could have been higher, so we could drive people away from smoking. But there are measures, and I think we ought to find a way through the health literacy to set these things up as challenges for the people of Kentucky. So here we are in these. Now we're going to measure these every year, and we're going to come back and say where we are then. But if you do these things, you can help us. And the second Sunday is where you actually get the whole community involved. Right. And then they self-educate. It's the word-of-mouth stuff that's going to help us. And we can tell them, but if they get to talking about and having a local conversation, then and putting some incentives in place, I think, is important too. How do we incent the people to take care of themselves? Sounds kind of odd, but that's what you almost have to do.
A lot of communities have community health coalitions that try to make health a community cause, and one of the recommendations at the breakout session I attended at the Health Literacy Summit was that every community ought to have a community health coalition to get people talking to each other. And part of this effort is to get people at the university talking to each other and people with similar interests. And part of this colloquium is a class, which is providing a studio audience for this program. And students and other observers are able to ask questions. So that's a reminder that if anyone in the audience has a question, we are prepared to pose it to the panel. I think it would help just to give some details about just what the outcomes of poor health literacy are. We have already talked about less healthy behavior, but other points include the inferior self-management of chronic diseases. People have a chronic disease and they really don't understand how to manage it and mitigate it. They tend to have higher use of hospitals and emergency rooms, higher mortality, and they make bad healthcare decisions, I think, too. Sometimes it's not so much a decision as the lack of a decision. That's another reason, I think, for it to be a community kind of effort. Do we have a question?
Hi, this question is for any of you to talk about. We briefly talked about direct-to-consumer advertising and how in this society we are bombarded with a pill for every ill. And I was wondering your opinions on, is this actually increasing health literacy and encouraging dialogue, or is it giving a false sense of literacy about issues that maybe aren't as important as other pressing issues? So I'd be interested to hear your opinions about these ads.
Well, that's a very interesting question. Who would like to take a crack at that one?
Well, I'll take a crack at it.
I saw you shaking your head.
I wish I had more research to back up my crack, but since it's just, asking an opinion, I think definitely that we're seeing more and more of that advertising. We're seeing the sale of those expensive drugs are increasing. We know that our country pays a higher share for those drugs than do other countries.
And the American pharmaceutical industry is the most profitable industry in the country.
There you go.
Yeah, right.
And even though I'm in the communications business and I'm a supporter of advertising, sometimes I really question the advertising of a lot of prescription
And I
drugs.
think in response to part of the stress of providers who have so little time with patients, one of the things that we hear from providers is that it's really hard to resist that customer or patient who's paying for your service who comes in and says, I saw X advertised on TV, can I try it? And you've only got 5 minutes with the person anyway, and that's not really the message that you as the provider want to be delivering. And it's a real mixed.
And neither you nor the patient can read all that fine print that takes up a whole other page in the magazine,
Whoever reads
right?
all that fine print.
All right, we have another question.
This question is for Dr. Stein. You were discussing some of the, that you teach some of the students in the College of Dentistry and that there are initiatives going out to help deal with this health literacy issue in Kentucky. My question for you is, you mentioned that there were sometimes patients come in and they have a reading level of about a first or a second grader. So what is it that the College of Dentistry here at UK encourages dentists or physicians to do to deal with patients that have a reading level of that capacity?
And while we change the cameras, I'll also add to that question, if you would please address the new procedure that's required for enrolling students to have dental screenings or examinations. But her question first.
Yes. Well, I think that's a good point. I mean, it's difficult to tell at what reading level your patient is at. And I think, most of the things that I am reading on health literacy is that we should be, everybody, universally, it's a universal precaution, if you will, to design all reading materials at 5th grade level or below. But the reality is we have patients sometimes that can't even read at a 5th grade level, lower than that. And so we're teaching the students to identify some red flags in their private practice. When patients say, they've forgotten your glasses, can you please read this for can you read this for me? Or, I'll read this later when my husband comes. Or, there are a variety of things that help practitioners recognize that there could be a problem. And so we're suggesting that when something like that happens, this needs to be a shame-free environment, but very helpful, and that those forms actually be read to the patients, the medical history, that the patient be very courteously and respectfully taken, and that help be given with reading. And it's actually suggested, the American Medical Association just ask the patient, how comfortable do you feel with your reading? And many patients will just say, well, not so well. I don't know, I feel like I read so well. And then that starts the discussion, and you're off and running with really helping them.
Does it perhaps help to say that many things dealing with medicine can be complicated and use jargon or specific terms?
Absolutely.
and
Yes.
make the reading more difficult?
Yes, and I think there's another technique that we use called teach back, which is you explain to a patient, let's say they've had a tooth removed and you need to tell them post-op instructions. You want to make sure that they remember. Some of these are really important because they could have bleeding. And so you say, you know, I've told you several things. What do you feel is the most important thing? Tell me a couple of things that you really feel are the most important. I want to make sure that I really did a good job explaining it. And then let the patient tell you, you know, this is what I felt was important.
Do you believe that the requirement for screening and examination of enrolling students is going to raise the level of health literacy when it comes to oral health?
I think it's a step in the right direction. I really do. I think that, you know, that puts us out there as another health requirement. You know, the mouth is a part of the body, and it does, what happens in the mouth impacts the rest of the body systemically, and you know, children have a lot of other health requirements to enter school, and I think it does increase awareness. And I think as a result of those screenings, parents are sometimes contacted when there are urgent dental needs. In our outreach programs, we have a report card that goes home with the kids, and they have a green light, they have a yellow light, or they have a red light. And the red light, and this is a health literacy issue, the red light means stop. You need to get your kid into the dentist immediately. They have a really bad tooth, and so that's another way of dealing with it. But I think it's a very good thing. Yes, it's a step in the right direction.
And we should note, I guess, that these certificates of examination have to be presented by January 1st, and this is the first year of this program. We have another question.
I'm interested what the panel thinks about the role of media technology in health literacy, such as using iPads in patient-physician interactions or things like that. So the role of media technology in health literacy.
Well, Mike, I'm the media guy, but I'm going to throw that question to you.
Well, thank you.
You're supposed to be an expert on all things.
Yeah, right.
Well, look, I think my general response is that it could be a very good thing. We know that a significant percentage of this country's population, as well as the state's population, have a challenge reading and processing text. Okay, just reading the information. So, you know, to the extent that the technology will allow and facilitate innovative approaches for delivering and presenting information on healthy practices, I think that would be very helpful. You know, there was a study that was done, really the only one that has been done nationally that I'm aware of. A massive study was done in 2003 to assess the health literacy of Americans. Mm-hmm. And what they found was that approximately nearly 40% of those people, Americans.
36%, I think, was the figure.
Nearly 40, man. Come on.
Got to be precise.
Had difficulty in processing that information. And you know, the goal is for folks to be at a proficient level, and only 12% were proficient. So we know that, and those are Americans. Okay, now Kentuckians would be probably lower than that.
We really don't have any Kentucky-based research in terms of health literacy, do we?
So any kind of technology that could be used to present the information in innovative ways would be good.
And I think there's some other things that are being done too that present the information to different populations. Where I work, we do some work jointly with the Centers for Disease Control around sexually transmitted diseases and getting messages out to youth. And there are lots of neat things being done technologically with email messages and videos and sort of soap operas that play. I don't even know what some of this is. I'm too old, but you know, little soap operas that play on my little iPod that I can watch. I think the health officer, Dr. Troutman in Louisville, is just starting to do messages that come to your iPod or BlackBerry or whatever you have to remind you not to smoke every day.
Yes,
and kids are getting a real edgy kind of message, and then adults are getting a second message that is really projected to be what target, you know, what resonates with each population group.
These devices, iPhones, BlackBerries, handheld computers, are increasingly going to be where people get their information.
Yes.
And the fastest growing form of media today is downloaded video. Its increase is exponential, and I think it has a good deal of potential for this area. I can see commercial messages being intertwined with health literacy messages. You know, if pharmaceutical companies are going to take a rap for being highly profitable, maybe they would want to, you know, through this medium, which after all is low cost. Once you set up the initial hardware, maybe that would be a good thing for them to do.
Let me just add one thing on there. I want to put a plug in here for Chris Kimmel and the Kentucky Science and Technology Corporation. And not just because Dr. Todd helped start that entity many years ago, but what Chris Kimmel and his folks are doing is actually working with a group of gaming experts at the University of California at Berkeley to develop a web-based game to, well, it hasn't been rolled out yet, but the idea is to entice young people into playing this sort of virtual reality game that will teach them and reveal certain truths about pursuing healthy lifestyles. And at the same time, it's based on this notion that the collective behavior of the players of this game will reveal some sort of collective intelligence that then the researchers can glean and perhaps uncover unique ways to approach this particular audience. So the technology is really, I think, provides a lot of opportunity to get some leverage over this problem.
Yeah, the whole game technology is something that operates under the radar of most Americans, but it is a fast-growing and highly developed field, and there's lots of money in it and lots of interest. We have another question.
Yes, thank you. After hearing so much about all of the wonderful programs that are going on at the state of Kentucky in terms of both oral, mental, physical health, we are still yet in the bottom of many of these lists. What do you think we have not done? Or from a research perspective, what can we do? What can the academic community provide to you to decrease or increase some of these numbers to provide a more healthy Kentucky?
Mike, you said you were prepared to give some policy recommendations, so you want to take a crack at that one?
Well, look, I think that you know, we are combating a historical legacy in this state of undereducation and poverty, and it will take many years to overcome that. When you look at the data, you see that as education, when you look at health outcomes broken out by educational attainment, say less than high school, some college, 4-year degree or higher, you see huge differences, okay? So, and our state is becoming more educated. We've tracked this back to really the early 90s when we had fundamental transformation of the elementary and secondary education system, and then in the late 90s with post-secondary. And Kentucky has steadily improved in both its educational attainment and educational achievement indicators, and we're continuing to improve, both in a real sense and also relative to other states. That, I hope, is going to continue. And as long as it does, our health outcomes are going to improve. But we've dug ourselves in a big hole in this state, okay? And it's going to take a long time to get out of that.
Dr. Scott?
One thing, and I was going to say this after the prior question, but what's exciting to me is that we have a bunch of young, bright people who are coming here, and I think this millennium generation is one of the most caring ones that wants to be publicly involved and wants to bring change. We have a situation, if we only had this small of a problem, to have an impact it would be kind of hard to measure. We got this big a problem. And you can actually tell if you instrument something in a particular county or a target area, you can see whether you're making a difference or not. I think there's a tremendous opportunity here for research, for bringing new ideas about how to use Facebook, how to use Twitter, and all of these things to reach a population that these students know better than what we do. And I think it's going to be up to them to figure out how to get to them. I still remember when I first had lunch with Coach Calipari after he became our coach. He walked in, he said, you know, I've got 80,000 people follow me on this Twitter thing. And he said, before the season starts, which is going to be 3 or 4 months, he said, I'll have 100. Well, he's got over 1 million now. But his next question, which gets you inside his mind a little bit and how he thinks, he says, the real question is, what do we do with them now? And so we actually send out, I gave him a cheat sheet of things to send out through Twitter, like, did you know that UK's pharmacy college is one of the best in the country, and so forth, and he's very willing to do it. Well, we need to find ways where, and we can use our athletics. They're doing work right now with to get food to children who go without food over the weekends, and that's something Mitch Barnhart's really wanting to be involved. We need to use what assets we have, and one of our big assets is sitting in this audience with the brain power of these young, bright, caring students who know the gaming stuff. And I would add, the other Dean O'Hare, Dean Mary John O'Hare, is really experienced in gaming innovation for education, and we've announced a P20 Innovation Laboratory, one of only 6 in the country, where 17 of our colleges are going to be involved with K-12 and trying to get innovative learning into those schools. And health is one of the main things that they could get through there. And the gaming idea could be a way that you could have several master's theses, I think. And we've got great target audiences in this state to try new methods. Even doing an inventory of how we've tried to get the word out before, because it hasn't worked. You know, we're doing things, but we're not doing them systemically enough to make them stick. And so I'm encouraged by this conversation and the fact that we've got people who can pick this up and run with it now.
I think what you said about athletes is interesting, because in order to be successful, athletes have to be in good physical shape, but they have to have good health, and I think they could be deliverers of excellent testimonies of the need for maintenance of health and being health literate. Next question.
Yes, this question is primarily directed for Dr. Stein, but anyone on the panel can answer. I just wonder, with poor oral health and other high-risk behaviors, such a big part of the culture of Eastern Kentucky, how can we fight that culture or make these health literacy initiatives, even integrate them into the culture of Eastern Kentucky and other problem areas?
While we're changing cameras, I'll add that while Eastern Kentucky is the heart of a lot of these problems, we have many other rural areas in the state and the rest of rural America where they are just as bad.
Urban areas too.
And urban areas too. You got to forgive me, Mike, I'm the rural guy here. Dr. Stein.
Well, I'm from a very small rural community in northeast Kentucky. And
now tell people where it is.
I'm from Carlisle, Nicholas County. Was born and raised there. Practiced there for 13 years with my dad. And I think the answer to that is grassroots movement. I mean, you have to get to the people in the community that are trusted, and sometimes that's a grandmother or a church group, a youth leader. If you can get a champion in a neighborhood or a community to get on board with what you're trying to communicate, I think that's really, you have to work from the inside. You can't have an outsider coming in telling about the importance of these things. They're just not trusted. They're not accepted. You have to work with somebody within the community that's trusted, that can be a role model and a champion. So I think those kinds of things are very important. I can't remember the second part of the question. Was that it?
I'm sorry.
What do we do in Eastern Kentucky?
But, you know, I would just add to that, what I think is interesting is how do our students get out there and figure out who are the communicators in these rural areas? You know, who do people listen to? Who has influence? And how do they have their influence? Where are those meetings held? Because different communities are going to have different ways of getting that message out. I'm from a town of 2,000 people, and I could name you the people that had the ability to influence behavior in that area. I still go back to this. The Southeast and the Southeast Conference presidents meet once a quarter, and we talk about a lot. Why is the Southeastern Conference so competitive athletically? It's because something we could win. You know, we could do that. And what will it take to take that same mentality and focus it? If you just go into one parameter for one county and say, let's get the obesity, let's get the body fat down, and we're going to do this as a community. I agree with you totally. You cannot do it from the outside. But there is a way that our people can coalesce behind their support of a given cause, and it's typically athletics, and we need to leverage that. And I think our coaches would be glad to help if they have a way to be involved.
You mentioned earlier the role of rural media, and that of course is my responsibility. And we found some interesting things in our work. Dr. Laura Hall Downey, who got her doctorate in public health from our College of Public Health, and I worked together on a little community health outreach program in Morgan County, and she went to the University of Southern Mississippi, and she and I worked on a project to interview editors of rural newspapers in Kentucky and Mississippi about health coverage and why they did or didn't cover the subject. And they almost all acknowledged that they needed to do more with it, but they were very reluctant to do anything approaching a crusade. Most weekly newspapers do not have a strong editorial voice for any number of reasons. I believe that, that this is one of those causes on which there's really no countervailing side other than ignorance. You know, it's a motherhood and apple pie issue, and I've been telling these papers for 3 years, if a news outlet can't take a stand for better health and better health care, then what in the world can it stand for? So I think it really helps to get these media outlets involved, but they are all locally focused. You know, they're about local news and local service, so it takes the key local people, the influentials that you just mentioned, to go to them and get them on board. I might be able to plant a seed, but they've got to put the water on it.
Absolutely.
You know, there was an interesting piece in the Lexington Herald Leader. I think it was in the last week. It was an opinion piece that the paper ran that had been published somewhere else before. But basically, it was, I won't call it a diatribe, but it was a pushback, okay, against attempts to regulate one's eating habits, if you will. And sort of the whole tenor of this piece was, look, I enjoy eating, you know, whatever, you know, cupcakes and French fries and ice cream, and I want to do it, and that's my business, and it's not your business, so leave me alone. And to me, I thought, you know, that's sort of indicative of this movement that we see going on politically across the country, the Tea Party movement, of this kind of pushback.
Government, please leave me alone.
Yeah, and as I read that, I thought, to me, that reflects that sort of wider underlying current, but I just fundamentally disagreed with it. You know, there was a CBO. I'm sure you're surprised that I fundamentally disagreed with it. There was a CBO,
Congressional Budget Office,
a Congressional Budget Office report that came out about the same time last week, and it was about the cost of obesity. It was about the health care costs of obesity, and they said. It said 1987 that an obese American, the per capita health care costs for an obese individual was about 8% higher than a non-obese individual, okay? Fast forward 20 years to 2007. It's not 8% now, it's 38% now.
and there's a lot more obese people.
And there's a lot more obese people. Now, what are the implications of that for me as a citizen, as a taxpayer, as someone who has to pay for health insurance? Okay? Well, the implications are that my health insurance premiums are higher, my taxes are higher, and so on. So it is not just their business, it's also my business.
Yeah, I think people who object to the socialization of health and health insurance have to realize it's been socialized for a long time. Ever since we had health insurance, you know, there's always been a sharing of costs.
That's the whole part behind pooling.
Yeah, right.
What I'd like for some of those folks who have those opinions, both politically and health-wise, is what is their solution to the nation's problems? And they don't really think that's their responsibility. And I liken them a lot to the talk radio folks that I don't listen to much anymore. They all have opinions, but they have no responsibility, or they take no responsibility. And that's where the incentives were mentioned before, and you do get a premium increase if you're a smoker in health insurance. Right. And there are ways that could be dealt with, and employers are taking positions on some of the health care because it's eating employers. We have had to become much more consumer-centric with our health plan to keep the cost down. And it is clearly shown that once we started putting in higher co-pays or started doing things with emergency room visits, they reduced. And I don't think the health care has gotten any worse. But
I think one good argument that can be made in local communities that need jobs or better jobs is that employers increasingly look at the health of a workforce, a potential workforce. And if they see that a community or a region has these bad health statistics, they are less likely to come there. And you know, if you can translate this to the bottom line, then you might be able to get some money and push behind local health literacy efforts.
point.
Well, I thank you all very much for a very interesting discussion, and thanks to our students and observers. This concludes the first in a series of discussions in our health colloquium. Good day.